All right, here we go. Hello, and thank you for watching this program on high deductibles, cash plans, and prepays. There's no audio taping or videotaping allowed, and any unauthorized reproduction, dispensing, forwarding, or copying of this target coding presentation is illegal. The information contained in this presentation is for educational purposes. It's not intended to be legal advice. Target coding does not engage in providing legal services. CPT is a registered trademark of the AMA. Every attempt has been made to make certain that the information in this presentation is 100% accurate. However, it's not guaranteed. A little bit about myself before we get going. My name is Dr. Marty Kotler. I'm a chiropractor. I'm also a certified professional compliance officer. I'm a certified billing and coding specialist. My areas of expertise include CPT and ICD-10 coding, compliance as it relates to Medicare and HIPAA, creating record-keeping, treatment plans, and compliant cash plan programs and training to thousands of chiropractors across the country. Been doing this for over 12 years. I've written many compliance and documentation training manuals. I write articles to numerous publications and journals across the country like American Chiropractor, Dynamic Chiropractic, Chiropractic Economics. I also write newsletter articles for many state association journals and newsletters. I also am a guest speaker at many state association conventions nationwide. So let's begin with fees. Before we get into the deductibles and co-pays and co-insurance and all that fun stuff, let's just begin with fees. How much should you charge? You know, that's a very common question I get, especially from new graduates. I work with a lot of students that just graduate, and they go, Dr. Kotler, how much should I charge? I'm opening up a brand new practice. How much should I charge? Good question, right? Well, let's break down a fee. There are three factors that typically determine a fee: work and skills utilized by the provider, your overhead and administrative costs, and the malpractice expense of the provider. So now again, how much should I charge? You know, I do an exam, I take x-rays, I do a chiropractic adjustment. Well, you could do a very formal calculation by finding out the RVUs and multiplying them by the conversion factor for your area. There are many good references. One of the best is the RBRVS Physician Guide, RBRS, Relative Based Value System. You can take a look at what other providers are charging in your area. Be a secret shopper. Try and find out what other doctors are charging in your area. You want to be competitive. Unless you're doing something unique, that's a whole nother ballgame. But if you're doing the same thing as everyone else pretty much, and you're charging 3 times more, you're probably going to have less people coming to you. If you do something unique, something different, then yeah, you can charge a lot more than your competition. Take a look at what the fee schedules are in your area. Take a look at the Medicare fee schedule. If you're going to go and network with any plans, take a look at the fees that are attached to the services you provide. And your fees should be reviewed annually. You know, sometimes you have to decrease your fees because of the competition, but most of the time you should have a little bit of an increase every year or 2 years or 3 years. I know some chiropractors in practice 30 years. Their fee is the same from 1998 to now, you know, so you want to reevaluate your fees. You don't want to get stuck using the same fees over and over again. And some people get stuck using the same fees over and over again because that's all the insurance company will pay. Not a good idea. Now, another great source for fees is this website, fairhealthconsumer.com. You know, sometimes I'll have a doctor contact me or a staff member say, we have patients complaining that our fees are too high. Okay, well, how do you answer that? You know, well, one of the things I would recommend is you tell patients, well, you know, we don't necessarily set the fees. The insurance industry and consumers help set the fees. So if you go to this website, put in your zip code, and then put in some of the CPT codes that you charge, you'll see that the fees that come up on this website are typically much higher than what the typical chiropractor charges. So you could tell patients, go to this website. You think our fees are too high? Go to this website, put in your zip code, and you'll see what the average price is in our area, and you'll see we charge less. So fees are important. And by the way, here at Target Coding, we have a fee schedule calculator. We charge a small fee to figure out what the fees should be in your area. We will put them into our little calculation here that we have the conversion factors and the RVUs for the entire country, and we can plug in your zip code and the CPT codes that you charge and come up with what we think would be a fair fee for your area. So contact us if you'd like to get your fees calculated by us. Next, is one fee really possible? Can you charge the same fee to every man, woman, and child? And, I hear that too, Dr. Kotler. You know what? I don't know if I want to bill insurance. I'm not sure I want to be in network with these plans. I just want to charge I want to charge $50 for my adjustment. Every man, woman, and child that comes into my office, I want $50. Is that possible? Probably not, because of this. There's many different fees. There's normal fees. There's like $50. It could be your normal fee. Then you have managed care. If you're in network with a plan, say, you charge $50. Well, that's fine. We only pay $45. So you have to write off $5. So your fee's $45, right? That's different than $50. And then you may be treating Medicare patients. Well, if you're treating Medicare patients, that's a mandated fee. So it could be only $35. Well, my normal fee is $50. Well, Medicare only allows $35. Okay, so there's another fee. And then you might see workers' comp patients, and that could be a different fee. And your PI patients, that's a different fee. So, and your cash fee could have a little bit of a discount. So, wait a second, my normal fee is $50. Managed care pays me $45. Medicare is $35. So is it possible to have one fee across the board for every man, woman, and child that comes into your office? Probably not. Now, being part or some or all of these categories you see on your screen doesn't mean you have a dual fee schedule. And, you want to be profitable. What do I mean by that? Have you ever calculated how much it costs you to deliver an adjustment? I'll explain it to you. This is important to know. How much does it cost you to give somebody an adjustment? So let's say your monthly overhead, let's say, is $10,000. We're talking about your rent and all your bills, salaries. Let's say your rent is at $10,000. And you're a chiropractor that sees 100 visits a week or 400 a month. So 10,000 divided by 400 is $25. So in your case, if those were your numbers, it costs you $25 to give somebody a chiropractic adjustment. Now, I've done this calculation with many providers, and sometimes this number comes out to, let's say, I just did one recently, $35. And then I asked the doctor, how much do you charge your cash patients? And he said $30. I said, wait a second, it costs you $35. Why would you do an adjustment only for $30? A patient like that comes into your office, you might be better off just, handing the patient $5 and tell them to go home. I'm just kidding. I understand some patients can't afford your full cash discounted fee, but you should know how much it costs you to do an adjustment, and keep your fee simple. Fee confusion is difficult for patients. It can cause, state board complaints, and all patients should be aware of your normal fees if you're providing discounts. Some providers give discounts without advising patients of their normal fees. And what can that do? That can cause unnecessary confusion. If a cash patient returns as an insurance patient, I call it sticker shock. So be careful with that. Patient education is more important now than ever before, addressing the medically necessary services versus wellness care. Patients come in, they go, well, I called my insurance, I'm covered for 30 visits. Well, you're covered for up to 30 visits, right? So patients need to know, that fine line between medically necessary care and wellness care. Yeah, here we go. Chiropractic wellness care versus medically necessary care. Well, and if you want to break it down into two categories, every single man, woman, and child that comes into your office, you could break down into two categories. Here they are. on your screen. In my opinion, everybody would fall into one of these two categories. It's either active care. Active care means medically necessary care if insurance is involved. So we have active care and wellness care. So active care means pain, restricted motion. You see the graphic right under active care? This patient is holding his back. He has pain. He has discomfort. He has difficulty bending and lifting. That's active treatment. You can consider that active care or active treatment. If the patient has insurance, insurance will pay for that. Well, it's a covered service, let's put it that way, because the patient might have a huge deductible, but chiropractic is considered a covered service when patients have symptoms like decreased pain, restricted motion, decreased ADLs, or the patient might say, I don't have insurance and pay cash because they're in a lot of pain. And then we have the second category, which is wellness care. Patient pays cash. Insurance doesn't pay for wellness care. So if a patient ever called an insurance company to verify coverage and said, hey, just curious, does my plan cover chiropractic? The patient is going to hear yes most of the time, as long as the care is medically necessary, right? So medically necessary care means insurance payable. Wellness care, prevention care, maintenance care is not medically necessary. When you hear the word active treatment, you may think of Medicare with the AT modifier. That's medically necessary and payable. So again, that means the patient has pain, restricted motion. Now the patient gets to the point, very little pain. Range of motion is pretty normal, and the patient could do most of their ADLs. That becomes wellness care, and that's not payable. Performance enhancing care is not payable. I had patients coming into my office saying, Dr. Kotler, I want to hit the ball further. I play golf. I heard you take care of a lot of golfers. I attracted a lot of golfers into my practice, although I don't play golf that often. A lot of golfers came into my practice, and some of them would say, hey, I heard you help my friend Jimmy hit the ball another 25 yards further on the tee off. I said, and then the patients would go, can you help me hit the ball further? I said, of course, come on in. But insurance doesn't pay for me to help you hit the ball further. So that's a performance enhancing care, which is not payable. So when it comes to, what is medically necessary, it depends who you ask. If you ask Aetna, they consider the care medically necessary if the patient has a neuromusculoskeletal disorder. The treatment is clearly documented and improvement is shown within the first 2 weeks of care. So when it comes to getting payment from patients, your staff, you need to have put pit bulls as staff members, because this is what happens. This was my viewpoint when I first started practicing. I would look out into the waiting room. From the doctor's viewpoint, I would see, oh, there's patient number 1. She has headaches. Patient number 2, rotator cuff. I would associate patients with their condition. I'm a doctor. I just want to treat their condition. Oh, yeah, there's Sally. She has knee bursitis. Oh, there's Beth. She has a herniated disc. The doctor, you want to take this viewpoint? Fine. But your staff better take this viewpoint. Your staff, looking at those same 6 patients, oh, yeah, patient number 1, I got to get a $20 copay. Patient number 2, I need, this patient is an ASH patient. I need to get care authorized after 5 visits. Oh, patient number 3, the brace got denied. Oh, patient number 5, cash patient. I got to get an updated credit card. Her credit card expired. Oh, patient number 6, insurance company's waiting for notes. So staff members, you need to be pit bulls, and all you need to be thinking about is, yes, you want to be nice to the patients, obviously, but you want to get the doctor paid. All right, now, deductibles, co-pays, co-insurance. Let's dig into this. Just a refresher, the deductible is the amount that is paid by the patient prior to the insurance company paying. Deductibles can range from as little as $100 to $10,000 or more per year. Co-insurance typically represents a percentage that the patient is responsible to pay out of pocket. Typically, this is an out-of-network situation where your normal fee is $150. It's a 70-30 plan, so 30% of $150 is $45. Copay is typically a flat fee that the patient is responsible to pay out of pocket. Same thing, example, I'm going to be using $150 as our, sample fee during this presentation. So with a copay, you treat a patient, your fee is $150, and the copay says, well, it's only $25. The copay is $25, then the patient only pays $25, and the difference between the patient copay plus the insurance payment and your total bill must be written off. And copays typically apply to in-network providers. Routine waiver of deductibles, copays, coinsurance is inappropriate because it results in false claims. And you could be considered misstating your actual charge. If you bill $100 and you routinely waive the 20%, then your actual charge is $80. So that can cause problems if you do that with federally funded programs especially. And this person got in trouble. This doctor, this provider got a letter from Medicare. It said, the purpose of this letter is to inform you that our office received a complaint alleging that you knowingly process Medicare claims as if the patient is paying their co-payments, but they're not. Not a good letter to get. Now, let's talk about high deductibles. How do we get around high deductibles? How do we deal with high deductibles? It's one of the biggest issues facing doctors' offices now. Staff members have difficulty explaining this to patients. Doctors oftentimes feel uncomfortable talking to patients about deductibles if they're very high, and if the doctor's out of network, how do you get past it? In network, there even could be a high deductible. Even in network, you could have $5,000, $6,000 deductibles nowadays. Years ago, that wasn't the case. Years ago, in network, there was no deductible or very low deductible, and out of network had the high deductibles, but now in network and out of network could have high deductibles. So let's go through some of the key points to get you to collect as much of the deductible as possible. As I just mentioned a few minutes ago, you're not allowed to waive the deductible. I'm not a fan of telling patients, don't worry, we'll accept whatever your insurance pays. Not a good idea. So let's talk about this. So the key points, you want to tell patients about their financial responsibility. Otherwise, confusion occurs. That's where board complaints can occur. Many times doctors have said, oh, Dr. Kotler, I've had doctors and staff members say, we forgot to send a bill to a patient. You know, that we forgot to tell the patient how much they owe each visit, and now we're going to send the patient a bill for $600. It was, $30 co-payments for 20 visits, and now out of the clear blue sky, the patient gets a bill for $600 that they weren't expecting. Or you told the patient it's only a $25 copay, but in essence, it was really a $60, and then you send them a bill. So it causes problems. I'm dealing right now with a few board complaints, helping chiropractors get out of these board complaints. Most of them are fee-related. One doctor I'm helping right now, a patient said, I want my money back after 16 visits. The doctor said, I'm going to treat you for 20 visits. And after 16 visits, the patient said, I'm not better. I want my money back. The doctor said, I'm not giving you your money back. The patient filed the complaint with the board, and this turned into a major problem. Well, actually, it wasn't with the fees, because the board came back and said, don't worry, you don't have to give money back to the patient. We reviewed the financial records you gave us, and we also took a look at your notes, and your SOAP notes are horrible, so now they're hassling him for his documentation. So careful with that. You want to have clear discussions with the patient. Now, if you can do an insurance verification prior to the financial report of findings, that will help you tremendously. If you don't do a verification of what their deductible is and what's covered, then the patient typically has no idea how much they owe per visit. Even the best, you as the provider and staff member, you may feel you're really good with insurance and you have health insurance for yourself. Many of you listening to this, you have health insurance. Let's say you sprained your ankle and you really badly, and you had to go to the ER, urgent care, or you went to your orthopedist for an exam on your sprained ankle. Do you know right now off the top of your head, if you have a deductible, how much you would have to pay? Is the doctor in network or out of network? Yeah, most of you don't know. So just think about a patient. they usually have no idea how much they should owe. That can cause problems, but if you do the verification prior, then you can give patients options on how to satisfy their deductible. So now when it comes to the deductible, in network or out of network, most of it is the same. So for example, you're going to bill your normal fees, and this is what happens. So here in this example, I have an adjustment at $50. I have an extremity adjustment at $50 and therapeutic exercises at $50 for a total of $150. So that's your fee, $150. And now the insurance company goes, okay, that's fine. You billed us $150, but we're only going to pay $75, $25 each. So, and that goes towards the deductible, right? So they didn't pay the $75. They didn't pay anything. $75 went towards the deductible. So you can have the patient pay you the $75. Now, here's where it can get a little interesting. The patient says $75. Well, what's your cash fee? Well, our cash fee is only $50. Well, then why don't I just pay you your cash fee? Why are we billing the insurance? Is the patient better off paying your cash fee? You know, sometimes your cash fee is less than the patient's copay in some instances. So, you know, you want to put the patient on a payment plan, that's fine too. And also, if you're out of network, the amount allowed, think about that. When it comes to the amount allowed, how much should you collect from the patient? So let's say you're out of network and you bill the insurance company $300, and the insurance company says, that's fine, you bill $300. We only allow $200, and out of that, we pay 80%. So, well, you know, we'll reimburse the patient $160. You could ask the patient for the full $300, but I think you'd be okay just having the patient pay you the allowed amount. Most carriers okay with that. I've seen them say, all right, you could bill this, but we allow this. So we just would like you to go after the allowed amount, not your deep discounted amount, because then you're turning this situation into a dual fee schedule. So you have some options as far as collecting the deductible money. You could say to a patient, you have a deductible, Mrs. Jones, so we're going to submit the claim. We're going to wait for the first EOB to come back, and then we'll let you know how much your responsibility is, and then maybe we could put you on a payment plan. So you want to wait for that first EOB? That's fine. It's a little risky because the patient might not come back after a few visits and you're still waiting for the first EOB, but the explanation of benefits will clearly say what the patient responsibility is. But sometimes you'll tell the patient, well, your responsibility is, you know, $40 per visit, and then the patient's EOB says patient responsibility $55 per visit. Who is the patient going to believe? You or the insurance company official document? Well, they might like what you have to say better. That's why you can put the patient on a payment plan. They should be paying something per visit. If the patient has a hardship situation, have them sign a hardship form, but hardship forms should be done sparingly. If you're doing it across the board, then that's where, wait a second, you should just be lowering your fee. Everybody shouldn't be a hardship, and I hear that all the time, Dr. Kotler, all the police and firemen that come in and all the teachers, I don't charge them their copay or deductibles. Why? Is there a hardship? Some teachers and policemen, they might have little side businesses. They're making more than the doctor. So, you know, just be aware of that. And patients could be put on a monthly payment plan. For example, if the patient has $1,000 deductible, they can pay $100 a month over 10 months. There's nothing wrong with that. You don't have to charge interest. You could have the patient pay out their balance due. And you could give the patient, say, a walkout receipt. They come in, they know they have a deductible, like in the earlier example, the $75, and they just pay you $75 each time they come in. You give them a walkout receipt. If you're out of network, that's if you're out of network. If you're in network, you must bill and follow the rules because you signed a contract. But when you're out of network, you can just give the patient a walkout receipt. They can pay you at the time the service is rendered. Let the patient submit it. You know, that's fine too. So there's a lot of interesting ways, a lot of creative ways, a lot of things you can do to get past the deductible. You just got to dig deep and come up with all the scenarios and take it on a case-by-case basis. Now, there's categories that we like to go through. Many categories. There's, you know, cash categories, like pay-as-you-go, prompt pay, prepay plans, hardship, managed care. So we're going to go through some of these. Let's first start with the cash fee, or patients pay as they go. Let's talk about this one a little bit. So I've just created a scenario here. Exams 75, x-rays 125. We're going with a 30-visit care plan. In your office, it could be a 60-visit care plan, maybe 12-visit. I've created a 30-visit care plan, so 30 adjustments at 40 each, 20 tractions at 30 each, re-exams, so the total is $2,100. Give the patient a walkout receipt if you are, if this is a cash patient, meaning no insurance, right? Pretty straightforward. Don't use these fees. This is just a sample for educational purposes. Let's go to the next category, which is the time of service. The time of service discount, or prompt pay, I like to call it, administrative discounts. Well, yeah, there's, let me just need to check something here. And we're going to continue in a minute. Oh. Okay, we're back. So we're talking about time of service discounts. So when it comes to time of service discounts, there's a, well, let's go over prompt pay, time of service, administrative discounts. Here we go. So prompt pay, it's designed to reduce the cost of debt collection. You can give patients discounts. Now, again, time of service discount, patient has to pay at the time of service to get the discount. What happens if they forget their wallet at home, right? You're going to say, sorry, you didn't bring your money with you. I have to charge my normal fee. So I don't really understand that time of service strict rule. I like to call it an administrative discount or a prompt pay discount. So it's designed to reduce the cost of debt collection. It's approximately 10, 15. You want to get a little bit, you want to go a little past that, 20%. That's fine. It's not based on the patient's condition. You cannot advertise it. You can only talk about it at the financial report of findings. And there's an opinion rule that came out by the OIG. Said, yeah, you can give a discount. It's just a very small amount, maybe 15%. This is from their OIG advisory opinion. This is number 0803 from 2008, where it talks about how you can give patients discounts. Now, there's also something called the $75 rule, which is you can find that from an OIG advisory bulletin from December 7th of 2016, where you're not allowed to give Medicare patients more than $15 of free service or a gift per incident, and $75 total for the year. So just a little heads up on that one. This is the OIG advisory opinion on prompt pays. Okay, next let's talk about prepays. So prepays, wonderful, terrific. A patient pays in advance for multiple visits. There's less congestion at the front desk when patients prepay. There's less administrative work. Patients that prepay, they very rarely miss their appointments, right? They understand the value of chiropractic very well. But just be careful, because offering prepaid plans to insured patients can violate in-network provider agreements. Typically, those in-network agreements prohibit you from collecting deductibles and copays in advance. We don't recommend that. And you might have to put the money into a separate escrow account. So, little information on prepays. Hardship. Yeah, most insurance companies require healthcare providers to attempt to collect the unpaid portion of the deductible, copay, coinsurance. However, certain conditions may permit a provider to waive, partially or full, the collection of the deductibles, and one of them is a hardship. So the federal government has some guidelines on financial hardship. Here's a financial hardship application for waiver and deductible. There's some formal information that you could take a look at, and there's a little guidelines here on what's considered, poverty levels, and if the patient, maybe you want the patient to bring in their tax return or some sort of proof, maybe from, their priest or rabbi that they're having some sort of financial problem, and you can reduce your fee. You could even give it away for free. Do you know if a patient comes in that does not have insurance at all, they are totally bare, no insurance, you can give your services away for free if you would like. Here's information on also from the federal government on discounting and a sliding fee schedule. If you want more information on this, let us know. Next, in-network. So if you are in-network, here, let's take a look at this. You're in-network. Same 30-visit care plan. The first 15 visits are medically necessary, and then the patient reaches maximum therapeutic benefit, and then they switch over to medically necessary care. Maintenance care. That's what MC stands for, maintenance care. So when you're in-network, you're required to bill for all the services. Check with the plan. You may need to provide specific forms or do, those medical necessity reviews when you're in network. You want to collect your co-pays and co-insurance. You want to bill your normal fees. When you're in network, you must accept the contracted fees. That's in network. Now, let's talk a little bit about out of network. Out of network, you can charge your full normal fee. You don't have to wait for the money. You could have the patients pay you at the time of service. I would recommend you have the patients sign a form that they understand that certain services are not covered and they agree to pay. You could even tell patients that for certain non-covered services, you're not going to bill. That can save you a lot of time and effort. Next, Medicare. Yeah, Medicare. Hey, I have a couple of questions. Can you treat Medicare patients without being enrolled in the Medicare program? The answer is no. You're either in or out. If you see Medicare patients, you must be enrolled. You cannot opt out and take cash. I get that question all the time, so I just want to clarify that. You're either in the Medicare program, actively have a Medicare PTAN number, and you're enrolled. That's the only way you can touch Medicare patients. If you don't have a Medicare number, you've never had a Medicare number, you let your Medicare number lapse, you just never enrolled, you should not be touching Medicare patients. You cannot opt out of Medicare. Can you collect cash from Medicare patients without billing Medicare? As long as you're enrolled and the patient checks option 2 on the ABN form, then yeah, you can collect cash. Actually, here's interesting, some people get a little surprised. What, Dr. Kotler? I cannot opt out? I just take cash? Read up on it. Do your research. Go to the Medicare Benefit Policy Manual, Chapter 15, Section 40.4. You could read about who and who cannot opt out of Medicare. Actually, if you're not enrolled in the Medicare program and you're not actively billing Medicare and you're seeing Medicare patients and just saying, hey, just sign the ABN form, that's also illegal. Chiropractors not enrolled in Medicare, you're not allowed to use ABN forms. What did you say, Dr. Kotler? Yes. Don't believe me? Go to the Medicare Claims Processing Manual, Chapter 30, Section 50.3. You'll see all the information on it. Now, a little bit about personal injury and work comp. So work comp in most states do not allow you to accept payment from the patient. PI may allow you to accept payment from patients. You want to avoid dual fee schedules. You see, this is where dual fee schedules come into place. For example, you're billing PI $250 a visit, and you do the same service on a cash patient, and you're charging $40. Whoa, $250 insurance, $40 cash for the same thing? You see how insurance companies could get upset with that? You see, now, I know I don't want you to feel bad for insurance companies, but you could see how they could say, wait a second, why are you penalizing us? Why are you charging us $250 and you're charging for the same thing $40 to a cash patient? You need to have a good reason. I don't think you'll have one. You could offer them that small prompt pay discount, but not that dramatic discount. And then we have DMPOs, another category here. DMPO is terrific. The one I recommend is Chiro Health USA. So that's the question I get, Dr. Kotler. Yes, we bill our PI patients $250 a visit, and we want to charge our regular cash patients $40. You're saying that's impossible? No, it's not impossible. It is possible if you sign up for a company like ChiroHealth USA. Without a DMPO, you cannot do it. I don't see how you can do it unless you're state board or you've checked into it. See, many times when I deal with doctors, they tell me what they have created as far as their financial arrangement, and I ask them, where did you find out? Who taught you that? Where did you get that? They go, oh, I just thought it was right. I thought I was doing it right. My friends are doing it. Not a good answer. If you're in trouble, you don't want to say, well, my friends told me to do it. If you're being accused of something, you want to have ammunition saying, well, according to the federal government, according to my state board, according to my scope of practice, this is the way I do it. So ChiroHealth USA can help. It gets around that dual fee schedule nonsense, and you join the network, the patient joins the network, allows you to substantially discount your fees legally, works with cash patients, underinsured patients. It could work with Medicare patients and high deductibles. Next, you're going to have patients coming in with health savings accounts and healthcare reimbursement accounts and FSAs, flexible spending accounts. My recommendation, give them a walkout statement. Simple adjustment, 75, you paid 75, and then the patient might say, well, I need codes. Okay, so give them the codes if you want to just use a statement, or you could use a 1500 form, and patients might be getting wellness. So use S8990 for wellness. Use S8990 for wellness for everybody except who? Medicare. It won't work with Medicare. So when you have all these different fees and rules and regulations and how you're going to go about things, and you want to prevent problems, that's, if I had to pick one thing we do here at Target Coding, it's about prevention. We're all about prevention. It's like a typical, well, many chiropractors are all about wellness. Many chiropractors I work with, the name of their practice is wellness. Main Street Wellness Center, so we are interested in wellness as a chiropractor. Many are, which is prevention care. Here at Target Coding, we're also into prevention, being proactive, how to prevent problems. One of the things you could do to prevent problems is you should have a billing and coding policy manual with your policies and procedures. So if a patient comes in and says, hey, I don't like the way things are going, whoa, wait, Mr. Jones, we have policy on that. You read it when you first came in. Think about it. Let's say you bought a shirt at Macy's and you were going back to Macy's and you say, I'd like to return this shirt. What's your refund policy? And Macy's says, we don't have a refund policy and we're not giving you a refund. You would be pretty upset. Or, yeah, here's our refund policy. Sorry, it doesn't pay, so you have to have policies to protect yourself, to prevent problems. So a billing and coding policy manual should be based on these 7 things. And there's 3 things there. I have them highlighted that you should really take a look at. Have policies and procedures on your fees. You're supposed to do an internal review of notes. Especially if you see Medicare patients, it's you need to have a billing and coding policy manual, or compliance plan is what some people call it. You should be logging your trainings in with your staff just in case somebody's going to give you a problem, a staff member complains to the board about you, or a patient files a complaint. You can prove that you've had trainings on fees. If you're going to hire a doctor to treat Medicare patients, put that doctor's name in the exclusions list. So it's a good thing to have a billing and coding policy manual, goes over the deductibles and copays and how you handle billing and coding. Staff want leadership and organization. State boards, you can prevent problems or mitigate fines and penalties with a policy manual, and it's good for the doctor. For example, many doctors do full spine adjustments, but only bill $98940. Wait a second, Dr. Kotler, you adjusted the cervical, the thoracic, the lumbar, the pelvis? Your notes say you adjusted all of those regions. Why are you only billing us $98940? That seems strange, right? So you want to have a policy that goes over that. So, just a few closing comments. Check with the carriers you bill prior to submitting claims. We can't guarantee this information will guarantee payment from insurance companies or patients. Just want to thank everybody for attending. Here's our contact information. Email, there's my face. That's what I look like. For those of you that don't know what I look like, a lot of people just associate my voice with PowerPoint slides. So there's my email, Dr. Kotler, DrKotlar @targetcoding.com. Email me directly any questions you have. Our website is targetcoding.com. There's our telephone and fax. Hey, you know what? We're on all social media platforms. Check us out on Facebook. Like us on Facebook. Follow us on Twitter. Check us out on YouTube. We have a whole YouTube channel. Definitely check us out on Instagram because we do offer specials on Instagram. For those of you that are interested in a billing policy manual, if you go to Instagram, you'll see, put in a code, and you'll get $100 off. So at Target Coding, we offer seminars, webinars, videos, on-site consulting, membership programs, even hourly consulting. We have a forms, letters, and templates binder that you could purchase. We do HIPAA and Medicare compliance programs. You know, speaking about forms, you should have good quality forms. When patients come in, you know, we do a forms review with our clients. So you want to have a good financial policy. You want to have acknowledgement form for non-payable services. Want to make sure you're filling out Medicare ABN forms if you see Medicare patients. And you want to have good HIPAA form, you know, that brand new patient form when patients come in. So have good quality forms. Make them look nice and clean. Here's our HIPAA form. Make sure you have the most updated HIPAA form. If you need it, contact us. This is the form that's required. If yours is dated prior to September 2013, you're using an old, outdated form. And make sure you read your HIPAA notice. If the patient doesn't want to read it and just sign it, that's fine. But you need to know what's in it. I have one doctor, he showed me his HIPAA form. It had all this dental information in it. He didn't read it. He just took his brother-in-law was a dentist. He's just using his brother-in-law's HIPAA form. Patients have to sign that they have the opportunity to get the form. And speaking of HIPAA, we offer a HIPAA compliance program. It's a comprehensive program. It takes about 3 months to implement. If you say, oh, we're HIPAA compliant, we don't need to do that, Dr. Kotler, then I just have one question for you. Have you done a security risk analysis? That's going to be one of the first questions if the HIPAA police come knocking on your door because a patient filed a complaint. You've had a breach. Your billing company had a breach. You have a disgruntled staff member. You have a chiropractor down the street that wants to report you. Regardless of how the HIPAA police ended up at your door, one of the first questions they're going to ask is, Doctor, have you done a security risk assessment? If you say no, you do not have a HIPAA compliance program. Even though you might speak quietly, even though you think you have that HIPAA form the patient signs on the first visit, and you lock your cabinet, and you even maybe have passwords on all your computers, if you do not do a security risk assessment and have it available for review, you do not have a HIPAA compliance program. Just a little heads up on that because here at Target Coding, we've become HIPAA experts. I think we are one of the leaders, if I must say so myself, in the industry on HIPAA compliance. So we offer a HIPAA compliance program. I mentioned a billing and coding compliance manual with policies and procedures. We do offer that too. How about acupuncture? We work with a lot of acupuncturists now, so we've put together acupuncture billing and coding compliance manuals with policies and procedures. And with one acupuncturist, this was the backbone of getting the doctor's fines and penalties reduced to almost a third of what he was asked to pay back. Of course, we do Medicare compliance plans. We also sell a book here at Target Coding. It's called The Book on the Best Chiropractic ICD-10 and CPT Codes to Improve Reimbursement. If you're going to diagnose, let's say, cervical brachial syndrome, we have some little tidbits here. What ortho neuro chiro test should you do? to substantiate that M53.1 code. Frequently asked questions. Most chiropractors, you ask them, what's the difference between a disc distorter and a disc displacement? They won't know. What's the difference between myalgia, myositis, myofasciitis? What's the difference between cervical brachial syndrome and cervical radiculitis? Most chiropractors do not know the answers, so we have a nice FAQ section in the book, and we give you the diagnosis codes that are considered long-term treatment diagnosis codes. In other words, the codes that pay the most visits are in this book. We have a whole bunch of cheat sheets that we offer, quick guides. We have a membership, $99 a month, pay as you go. We do seminars and webinars throughout the country. We have a physical therapy webinar coming up. I'm going to go over all the PT eval codes and the plan of care and Medicare requirements for physical therapists, and the therapy cap has been a huge change to the therapy cap. We're going to be going over that. And even if you cannot make the live webinar, you get your fee includes the live and recorded, and we're doing an acupuncture webinar coming up. So I want to thank everybody for attending. Again, my email is drkotler@targetcoding.com, website targetcoding.com. I want to thank everybody for attending. I hope you learned a lot.